Hey guys, Woodruff here. So now let's talk about fat embolism syndrome. We talked about compartment syndrome last. I didn't mention this, but compartment syndrome it can happen early when there's a lot of swelling and stuff like that, but it can also be delayed or happen later. But this is an fat embolism syndrome. Now getting to this one, this is something that usually happens more acutely. It happens usually the first 24 to 48 hours. You may not know this, but after you have an injury, a bunch of little fat clots are just kind of floating around. So having fat emboli is not a bad thing. Fat embolism, like little fat emboli by themselves, they're harmless. People can have them, especially after a fracture. But when they become embolism syndrome, this is where they get to the point where they start leading to blood flow issues. So think of the same thing as this is like having blood clots everywhere, except they're fat clots to the point where they are actually blocking very important vital organs like my breathing apparatus up here, my lungs, or my beautiful brain, or my beautiful, beautiful heart, and lead to some very serious issues. So there's mixed opinions about why and how these fats, the fat embolism occurs, or how this like actually happens in the body. There's some theories that talk about it's like the actual mechanical injury of, like the bone breaking that leads these fat globules to, get out into the rest of the bloodstream and lead to this syndrome. There's some theories about chemicals that are released and things like that that can lead to it, but you guys don't have to know that in depth about that. It's more just realizing that what do you call it? There's a bunch of little fat clots that collect and create blockages and other issues throughout the body. And it's your job as the nurse just to be able to identify this. So how will we identify it? So, where do these little fat clots like to hang out? These little fat clots like to hang out in our beautiful, beautiful lungs and in our brain. They go everywhere. You can like that's why in this last picture you kind of see these petechiae here in the armpits and things like that. Those are like little fat clots that are chilling in the armpits. You might see these scattered all across the chest. Like it says, it's in the neck and the chest area, but they also can get most often they present with issues of not being able to breathe because all the fat clots are blocking their blood flow to their lungs. They also can have neurological changes because of fat clots getting to their brain. But on top of this, the main issue here is the respiratory, because the reason they also have neurological changes is because they're not breathing. It's what we call hypoxemia, or lack of oxygen. So in other words, when I'm not breathing well, my brain needs a certain amount of oxygen. And when it's not getting it, it's like, okay, well, I'm turning off. I'll come back on when I have what I need. So it's the same like when you drink too much, like you black out, and then your brain is pretty much like, okay, I've had enough. I can't function with this much alcohol, so it turns off, and it's like, good night, see you in the morning. And so it's the same thing with hypoxemia, where you just have a lack of flow of oxygen flow, which can lead you to be more sleepy, more confused. But this is the two priority assessments you want to do is a respiratory assessment and a neurological assessment. And so you're going to expect them to, complain that they can't breathe. They're going to be very anxious and restless usually at first. They can have chest pain, signs of decreased oxygenation. So like one of the priority labs that we might get is an ABG, because we're going to look specifically on that. What's the PaO2? Now, we didn't talk about that as much in our blood gas lecture, but that's the partial pressure of oxygenation, or it tells us, if you remember, the amount of supply of oxygen that we have in our arteries, which is what is going to be delivered to our tissues. So for someone that's having all these blockages in their lungs, they're going to have a decrease oxygenation. Remember, hypoxemia is lack of oxygen. So we'd expect that to be low in a patient with fat embolism syndrome. Because I do want to clarify, there's fat embolisms, but there's also what we're talking about here is fat embolism syndrome. And I'll have to update my PowerPoints before I post it. And so anyway, but yeah, so we're going to do a really good respiratory assessment, look for signs of poor oxygenation. I mean, and before we even do an ABG, you can just look on their monitor, and usually they're SpO2. So remember, PaO2, that's going to be on the ABG. That's and you can think of the the A and PA on the ABG is going to tell me how much supply I have. Where my SpO2, remember, that's the finger probe. That's going to tell me how much is getting delivered. So think of the PaO2 as the Amazon warehouse, how much, supply, or how much what do you call it? How much do I have at my store, like in order to get delivered? And then the SPO2 is like, how much is like the delivery trucks, how much are they able actually to deliver to the houses? And so I would expect them to have a low SPO2. And then, like I said, going along with that. Now, I know this seems kind of confusing because I'm sitting here saying they might be sleepier, but I'm also saying they're anxious. So they're anxious because they can't breathe, but they also eventually, as time goes on, they can get sleepy because they can't stay awake because they're not getting enough oxygen. And also, they can have fat clots to their brain and stuff like that too. And they also can be more confused. So, really, I'm worried about this patient's oxygenation, and I'm also worried about their safety at the top. We can diagnose it a lot of times through finding fat cells in their blood, urine, and sputum. They're just kind of everywhere chilling because remember, this is fat embolism syndrome where there's just a ton, they're widespread. And then we also might see bilateral infiltrates on their chest x-ray. Now, you do not have to understand what infiltrates are, but it is just another piece of the puzzle to help diagnose this. Ooh, appropriate orders. Let's do this. A nurse is caring for a client with, I should say, fat embolism syndrome. For each of the following prescriptions, because fat embolism is just one. It'd be okay if it's just one. But this is fat embolism syndrome. So for each of the following prescriptions, please indicate whether it is indicated, contraindicated, or unnecessary for the treatment of the client's fat embolism syndrome. So A says normal saline at 100 milliliters per hour. So if I'm thinking about this, there's all these fat globules. There's too much of something in my blood. Generally, when there's too much of something, I usually want to dilute it and make it better. Because one, it helps my kidneys to get rid of anything extra, but two, it also what do you call it? Helps to dilute anything there's too much of, so the body's not feeling as much. Like it kind of thins it out. Think of like the same stuff we talked about for like blood clots, that like more hydration helps with it. Now, these are not blood clots. It's really important differentiation for you. But the fluids can definitely help thin things out. So I'm going to say yes. I'm not just yes. I'm going to say indicated. This is what my son does, by the way. He does like this. I would be like, are you doing okay? And he goes, yes. And so yes. So I'm going to do the same here. Indicated. Enoxaparin 80 milligrams BID. So a patient with a fracture may need some blood thinning things, but it's asking specifically which prescriptions help with a fat embolism syndrome. Now, this is not a blood clot. Can a blood thinner help to thin a fat clot? The answer is no. And so this is not necessarily contraindicated. It's not necessarily going to cause harm, but it's not going to help with their fat clots. So it is you or unnecessary. You. It's kind of a weird you. That makes me seem like I'm doing this, but you. I just can't make you. Okay, like maybe like this. Still looks kind of stupid. Anyway, so unnecessary. Oxygen protocol to keep SpO2 greater than 95%. So with this, I would say that respiratory assessment's very important. They have low oxygen issues, so it seems like I'm going to need to do something to give them extra oxygen. So oxygen protocol means that I am giving supplemental oxygen to support a patient, and I think it's reasonable to think that a doctor would order, hey, you can put oxygen on to keep their oxygen above 95%. Titrate it. So yeah. All right. So that I would say is I for indicated. And so keep the client's head of bed less than 30 degrees. So this patient's having a breathing issue, hypoxemia. It's really going to be key that their head of bed is up, not down. So this is going to be one where it's not that it's unnecessary. I think it's actually contraindicated. I already did a thumbs down for unnecessary, so maybe I should do thumb middle for unnecessary, thumbs down for I heard something. It's just always ghosts in my house, don't mind it. Keeping the head of bed less than 30 degrees, I'm going to say contraindicated. That could actually cause some harm. And that's what, remember, for a question like this, indicated means it helps, contraindicated means it hurts, and unnecessary means it doesn't do anything or make it better and it doesn't make it worse. It's not specific or helpful in treating that. So most people can get the I and the C. They struggle with the unnecessary. Sometimes they struggle between, is it going to hurt them or is it just unnecessary? So questions like this are great practice because sometimes you might not have this kind of question, but you have something similar. So yes. Neurological assessments every 4 hours. So some people might get caught up on every 4 hours, but it's just saying, really, this is asking, are you going to need to do frequent neurological assessments? Well, I think yes, because they're having a neurological compromise, change in level of consciousness. So I'm going to need to monitor it pretty closely. So I'm going to say I indicated. Hydromorphone, 0.5 milligrams Q4 hours. So this is one where some people might get stuck. They might go ahead and say, "Ooh, contraindicated. It's going to decrease their level of consciousness and stuff more." And that's very true. So I would actually probably, I would probably not. Now, of course, I like when I'm talking them out, then I think deeper about them. When I wrote this, I didn't think this deep about it, but I would say, like when I originally put this, I was going to say it's unnecessary because fat embolism is not a pain issue. When we talk about compartment syndrome, that they have pain with that. There's no pain here. There's anxiousness because I can't breathe, but there's no pain. So there's really no need for opioid analgesics. Now, will they maybe need the hydromorphone for their general pain for their fracture? Yeah, sure. But is it going to treat the fat embolism? No, there's no pain management needed for this. So it's definitely either C or U. Now, I would accept unnecessary because it's not going to really do anything, but you could also say contraindicated because it's going to suppress their respiratory drive, which can worsen their hypoxemia. And then also, what was I going to say? Changes their neurological status. So it's going to be harder to do a good neurological assessment. So it's probably more like contraindicated versus unnecessary. Last but not least, vancomycin. So it's saying, would an antibiotic help me to treat fat embolism syndrome? Is it an infection? Is it going to hurt them? Probably not. It's not going to make their breathing worse or their neurological status worse, but it is unnecessary. So you've got normal saline, indicated. Enoxaparin, unnecessary. Oxygen, indicated. Head of bed less than 30 degrees, contraindicated. Neurological assessment, indicated. Hydromorphone, contraindicated, or I'll take unnecessary. And vancomycin, unnecessary. There we go. So what are we going to do then? Mostly we try to prevent this. So with compartment syndrome, like frequent neurovascular assessments are helpful. For fat embolism syndrome, pretty much the best thing that I can do is to try to minimize the movement in that limb. So let's say this patient's waiting to go to surgery. I want to make sure their leg stays immobilized. I don't want them moving a lot until they stabilize that fracture. Oh, excuse me. Before they stabilize that fracture, I do not want a lot of movement because remember, one of the theories around fat embolism syndrome is that the stuff gets broken off because when the bone's not completely stabilized, that's where more fat clots can slip out. So pretty much, I do not want to move it a lot. So one of my first top priorities when I have a fracture patient is immobilization of that limb. But once someone has fat embolism syndrome, most people can recover from this unless it's very severe or we don't get immediate treatment for it. But really, there's no treatment or cure for fat embolism syndrome. There's no way to get rid of the fat clots. We just have to support the problems. So safety, airway, breathing, like we said, we talked about helicopter. I'm a squirrel, don't mind me. Squirrel. Fluid replacement, like by diluting those globules, promoting hydration is also going to help protect their kidneys. These patients can also have hypotension and other issues and stuff too. So it helps on multiple perspectives, but mainly we do it to dilute the globules and support them hemodynamic wise. They may need other meds too. I don't include this on the slide because it's deeper stuff, but they may need medications like positive inotropes that help the heart to squeeze better. They may need vasopressors to help squeeze or constrict the blood vessels. There's a variety of meds, but they might need blood pressure and other support. A lot of these patients end up needing mechanical ventilation if it's severe. There also is ECMO or other treatments. Effectively, think ways to help with oxygenation. Some of these patients might be just on other oxygen devices, but just think of this as oxygen is a treatment. And then support their respiratory status and their neurological status. So safety, preventing falls, preventing any if they're not conscious or because of the hypoxemia, keeping them in a position that's going to support good breathing, but prevent them from aspirating like their head of bed up and stuff like that. Respiratory treatments, we already talked about the oxygen, but it's effectively just frequent assessments and supporting oxygenation and preventing issues with their change in neurological status, whether they're in kind of more of a decreased level of consciousness state or if they're having other issues like they are really anxious, restless, confused, then I just want to protect for their safety, reorientation, stuff like that. But yes, we just then the fat globules are eventually absorbed, and a lot of these patients, like I said, do get better. All right, the next video will be about other complications from fractures. See you for that one.